Welcome to Medical Testimony Masterclass. I'm Arlin Crisco from CBN, and I'm here with Dr. Burton Bentley of Elite Medical Experts. Dr. Bentley, how are you doing today?
Doing well. Good to be back with you in the audience, Arlin. Thank you.
Definitely. We have an interesting case today that we're going to be talking about. It actually involves it's a catastrophic case. It's a medical malpractice trial from just last year. Michael Trentalange was the plaintiff's attorney on it from Trentalange Kelley down in the west coast of Florida. The plaintiff patient was a college student who suffered from a rare disease, diabetes insipidus, rare type of diabetes that caused electrolyte imbalances. She unfortunately collapsed, was taken to the hospital, and the plaintiff's theory of the case was that the sodium imbalance was overcorrected. It was raised too quickly. There were actually 4 physicians that made it to trial, 4 defendant physicians. But for purposes of what we're reviewing today, really we're going to be looking at 2 of the first physicians that cared for her. Were really apportioned the lion's share of responsibility, 98% between the 2 of them on a $68.6 million verdict. So quite a large verdict there. And today we'll be looking at the critical care expert, Dr. James Leo. And I guess my first question to you, Dr. Bentley, is in a case like this, as complex as it is, attorneys have different approaches in when they bring in an expert. Some like to bring in that expert very early on, while others like to wait a little bit and work the case up a little more. Where do you stand on that?
I don't think there's a one size fits all. So it's going to depend on the dynamics of the case. What are we looking at in terms of complexity, the legal team's familiarity with the issues, and the cadence at which we bring in experts. So in this case, for example, it involves an unusual disease, and we'll talk about that a little more, called diabetes insipidus. So that's not, a bulging disc from a car accident or a common medical negligence claim. Diabetes insipidus is an uncommon disease. Most attorneys, I would imagine, have not heard of it. Most lay people have not. Probably when you realize I've got an unusual disease and I've got astronomically high dollars. This is going to be an 8-figure case, no matter how you slice it. College student, permanent neurological injuries. That's a great time to get experts aligned early. And it's not that we need 12 experts out of the gate, but having a core expert with whom you can align early, understand the foundation, where the theory is going. Having that expert on early, I think, just pays for itself over and over in giving the legal team the familiarity with issues, understanding pitfalls, knowing how to navigate it, and the cadence at which to bring in other experts as well.
Right. No, that makes a lot of sense. And I guess then moving into, this was really a core expert here that the plaintiff's case relied upon, Dr. James Leo, as I mentioned. And what we'll be going through today is a little of his testimony on that management of that sodium imbalance and looking at various clips and how they presented that to the jury. And I guess the first clip we'll look at today is Dr. Leo discussing diabetes insipidus. It really is the condition that led to all of this, and the allegation that this was mismanaged with that complication in mind there.
Okay, and Arlin, one thing I may just mention for the audience, again, we're talking about a rare disease. You might be thinking, gosh, I don't have a diabetes insipidus case. I don't want to watch the next 10 minutes of this rare disease. I'd like to take one step above that. Diabetes insipidus, and we can talk about that in a moment, and the expert that you'll see will. It's a disease involving a number of different things, but what it comes down to is these huge shifts in your sodium level. The reason that's important is the management of sodium, in particular low sodium, what's called hyponatremia, that permeates a lot of diseases and a lot of cases. And it permeates cases that often have high 7- and 8-figure outcomes. When low sodium is mismanaged, as it was in this case, there are catastrophic outcomes if you survive it, permanent neurological devastation. So in fact, we've got another case that we'll be doing at some point, but a recent $47 million verdict. Again, this current case, 68.6. But a recent $47 million case that just closed with Sean Claggett and Jennifer Morales at Claggett and Sykes. Different disease, but the same thing, a critically low sodium that's mismanaged. And what's that mismanagement? They raised it too quickly. And that's where we'll dive in now, is talking about where do some of these sodium issues come from? Why is it so important to correct it slowly at a well-known, evidence-based, established rate so that you don't hurt and kill people? So again, this case will be on diabetes insipidus, but think of that broader construct. It involves the mismanagement, the overly rapid correction of a low sodium. So.
And that's a great point. And taking it from another direction, even though diabetes insipidus is very rare, it's a chronic condition that complicates factors once you get into the hospital. And there are a lot of medical malpractice cases that rest on some sort of chronic condition that the patient appeared at the hospital with, and allegations that was mismanaged or ignored, and that's what led to the catastrophic injury, kind of a cascading of complications based on that chronic condition that the defendants might have ignored there. So that applies as well in a lot of these cases, and how to explain that chronic condition is so important, because that really is the cornerstone of the jury reaching the verdict you want them to reach.
It is, and especially with a disease like this, again, most people haven't heard of it. How do you take a complex construct and really bring it to a level people can understand? And you'll see they do a pretty good job.
Let's talk just for a moment about diabetes insipidus and Langerhans histiocytosis. I got a little aid to help you. Okay, diabetes insipidus. Let's see the aid, and then you can tell us what that is. And specifically, in areas where there's a choice of one thing or another, let's apply it to Miranda Crohan, okay?
Okay.
All right, so what is diabetes insipidus?
Diabetes insipidus is a condition that results in the loss of normal control by the body of how much water gets excreted in the kidneys. So we maintain a balance of water versus sodium, the main salt in our bloodstreams, mostly by controlling how much water our kidneys excrete or hold on to. If the kidneys let out too much water, the concentration of sodium in the bloodstream goes too high. If the kidneys hold on to too much water, that water dilutes the sodium, so the concentration of the sodium goes too low. So and that concentration is very important to the function of cells in general. So the body has a very, in general, precise mechanism for controlling this by, first of all, thirst. If people's sodium levels going up, it stimulates thirst, so they drink more if they're able to. And if they've got excess water on board, the kidneys excrete that excess water, and that's under control of a hormone called ADH, or anti-diuretic hormone. ADH is, if you've ever heard of people taking water pills or diuretics to get extra fluid off, you can think of ADH as exactly the opposite. It turns off the spigot, the way this is shown here with a wrench shutting off the flow of water out of the kidneys. It causes the kidneys to hold on to water, return it to the circulation so that it doesn't get excreted.
Do nurses have a little saying that they use to think about it? They say ADH keeps water in the body and not in the potty.
I've heard that one before. So that's the role of ADH, is to tell the kidneys to reabsorb the water, not to put it out in urine, not to send it to the bladder to be urinated out. ADH is secreted by part of the pituitary gland in back called the posterior pituitary. And it's secreted when the brain senses that the concentration of sodium is getting too high, or really that the concentration of everything that's dissolved in the blood, a concept that we call osmolality. Osmolality is a measure of dissolved particles in a solution. So that could be sodium, it could be sugar, it could be potassium or other salts. When that goes up too high, the brain senses it, sends out ADH to signal the kidneys to hold on to water. And that, by holding on to water, that reduces the concentration of those dissolved particles, especially sodium, in the bloodstream and returns the body to a normal state. It's a constant back and forth in a normal person. In diabetes insipidus, the form we're talking about in the case of Miranda Crowan is diabetes insipidus that's caused by damage to the pituitary gland such that it can't secrete ADH.
Is that central diabetes?
That's also referred to as central diabetes insipidus. We call it central because the brain's part of the central nervous system.
Now, there you go. Now, I thought he did a quite a good job of breaking that down. One of the things that I noticed and wanted to ask you about is we talk a lot about using demonstratives to break down a very complex medical system or terminology. In this particular case, they used a demonstrative that was very simple. It was a cartoon. It looked a little bit like Schoolhouse Rock, if you remember that from the 70s. And they really broke that down with, you know, using the wrench, the pituitary gland, using the wrench to turn, you know, water on and off. What did you think of that demonstrative there as far as how it was presented?
It's interesting. So we know in hindsight, they got $68.6 million. So I'll say that was a great demonstrative. When it first came up, even I as a physician and someone who knows Schoolhouse Rock, it was a little confusing because there was a lot of things going on there in a tight space. And I'll be honest, I don't know that I even recognized it was a wrench right off the bat until he said, oh, and it's like a wrench turning off the kidney. So I'm sometimes a fan of a bit more modern but very clean demonstrative. So I might have done the exact same thing. I mean, that is clever, the pituitary holding a wrench and turning off a kidney to get those points across. So maybe it was just some of the artistry of it. I wasn't quite as much of a fan of. There might have been a bit of a clearer way. The reason that I mentioned clarity with this is, remember, this disease is called diabetes insipidus. I'll bet 99.9% of people sitting there when they heard the word diabetes are thinking of diabetes mellitus, which is the problem when we say diabetes. That's a sugar disease. Totally different. I mean, there's no commonality. They both have the word diabetes, but they're totally unrelated. So when it's a complex construct, and I don't even want to take a chance that a jury is going to get waylaid. Oh, wait, what's this have to do with my blood sugar or my insulin? I may have even started one step higher. Hey, today we're going to be talking about this thing called diabetes insipidus. That's not diabetes. What we talk about, sugar diabetes. That's actually called diabetes mellitus. Get that out of your mind. It's just a common word. What this disease is. So that might have been a nice branch point. I don't know that the jurors got confused, but there are diseases that sound similar, drugs that sound similar. If a lay person's ever going to get it confused, I do like to start a little more broadly. So to your point, big issues, clean demonstratives that aren't overbearing or confusing or anything like that. And then a great expert. I thought he did a phenomenal job, smiling, engaging, turning toward the jury, a lot of hand movements, simplifying terms. And then the attorney did a nice job kind of juxtaposing, well, don't nurses talk about, what this does? There's no urine in the body, when you're right. This hormone out in your body. However he said it, it was a nice little play there as well.
Right. And that's one of the things. I'm not sure if he mentions it in the clips we'll be reviewing, but he uses a couple of rhymes. One is actually essentially his theme here for the claims of malpractice. If you don't know, go slow on correcting that sodium imbalance. And one of the things that I thought he was very strong in with this particular expert is he introduced that theme and that that rhyme that would be catchy and stick in a jury's head. But then he reinforced it. He actually had the expert say it at some point in the testimony. So it became more, it reinforced that. And I think that is so important in these complex medical malpractice cases where you have so much evidence that you're being presented with, something like that, if you can boil it down to something that is very simple like that, that can stick in a jury's head or jurors' heads, it really can be very powerful and resonate. What are your thoughts on that?
Yeah, we know now we are the soundbite, Twitter, instant, change the channel generation. So the thought is to have these digestible bites. And we have to have this as a theme that pervades any complex litigation, whether it's in the medical negligence space or I don't care, intellectual property, it doesn't matter. If it's going to be a jury of our peers, we've got to have these digestible bites. What's memorable? What's understandable? So if we start getting too complex, so for example, there's a point in there where the expert was even trying to make a point that antidiuretic hormone, something our body's making, it's made in the pituitary. But he talked about it's made in the posterior part of the pituitary. The question is that really relevant? Now a jury's hearing another word, but it turns out it doesn't matter whether it's from the anterior or the posterior, it just happens to come from that part of the pituitary. Usually we're working with experts, just really think of what's essential, what draws the facts out, what's not distracting, like sugar diabetes versus diabetes insipidus. How do we simplify, clarify, but make it interesting, digestible sound bites? So I do agree with that.
Right. All right. And the next clip, I guess, we'll be going to is outlining the what this particular expert believes are the reasons that the first critical care physician, Dr. Furman, how he did not meet the standard of care.
You have a screen here. We're going to go through. I understand these are kind of bullet points about your opinions. Is that right?
That's correct.
And I prepared these after meeting with you, right?
Yes.
And we met to talk about this case and discuss your testimony, right?
We did.
And we've done that several times. We discussed what was in the records, right?
Yes.
And do you do that every time you're retained to give testimony as an expert?
Pretty much.
Okay. Now, you don't know that, but there's a gentleman, Mr. Willers, who was here when Dr. Furman was testifying. He's with a firm called Wicker Smith. Have you been retained by that firm to give testimony?
I have.
The firm that's representing Dr. Furman?
Yes.
Okay. So the first opinion is that hyponatremia should have been chronic until proven otherwise. Should have approached treatment as chronic hyponatremia, unaware of standard of care requirement to presume chronicity unless known to be acute. When you say he was unaware, is that because you reviewed his deposition?
That's correct.
Okay. So did you review the actual pre-trial testimony of the defendants in this case?
I did.
As well as the defendants' experts?
Yes.
Did you take all of that into consideration before you form these opinions?
I did.
The final opinions you're providing at trial?
Yes.
So the hyponatremia, this first bullet point, is that basically because of all the reasons we've just talked about?
It is.
The ability of the brain to adapt and the need for time for that to occur?
And the fact that you cannot tell by the symptoms that a patient presents with whether the hyponatremia is acute or chronic. Because as I mentioned before, the sodium may have been falling for some period of time, may well have been present and low for more than 48 hours, unless you have a laboratory result from the patient within the last 48 hours to tell you whether or not it was previously normal. You can't assume that a patient who presents with acute symptoms has acute hyponatremia. The symptoms are acute, that is, they are relatively rapid in appearance, but that doesn't mean that the condition itself that's causing those symptoms wasn't chronic. And for the reasons that I already discussed about the damage that can occur if you raise the sodium too quickly in a patient with chronic hyponatremia, the rule of thumb that the standard of care requires for critical care medicine providers is if you don't know with certainty, if you don't have a factual, clear basis for knowing that the hyponatremia is acute, that is less than 48 hours in duration, you treat it as though it's chronic. That's what's safe to do for the patient.
Hyponatremia is low sodium. The danger in this case and in all of the low sodium cases is we have to raise the level incredibly slowly. We don't go, hey, your sodium's really low. Let's get that back up to normal. You know, there's tons of things. You have a fever, I want to get rid of it. You have pain, I want to stop it. When you have a low sodium, there is a rate. It's published. It doesn't change. Every medical student knows it. We have to follow this rate and track it and check it. Because if it raises too quickly, if there's a blip and a jump and it goes up, you will induce what this patient got and what happens in all these low sodium cases, what's called this osmotic demyelination syndrome, or what we used to call central pontine myelinolysis. We still use that latter thing. It's just a term that explains a specific type of this osmotic demyelination syndrome. The point is when we correct sodium too quickly, it can cause cells to swell and, so to speak, explode. And those cells are often near the brain and brainstem, so it is catastrophic and neurologically devastating. So again, what this doctor's saying, if that sodium is low, unless you know something he doesn't know, if there's a chance it's been low for a while, and the body's used to it being low, we cannot correct it quickly. So unless we know for a fact it's less than 48 hours, at this low level, assume it's chronic. And if it's chronic, you've got to raise it back slowly. Key concept.
Right. And I thought he did a really good job of explaining that, breaking that down. The other thing that I noticed that I thought was very powerful was Michael Trentalange, before he jumped into that, noted that this particular expert had testified on behalf of the defense attorneys, which adds, in my opinion, a lot of credibility to that expert. This expert is not just a plaintiff's expert. They testify for both sides. So that's something that he reiterated there before he got into this and broke this down.
It's a brilliant strategy. So let's be honest, the expert's allegiance should be to the facts. It should be to an evidence-based posture. That's ethical, that's professional, it's their duty, it's their reputation on the line. So I don't expect an expert to go in and be pro-plaintiff, pro-defense. I mean, that's a paid expert. So this is a big fish expert, and he's coming in and telling it like it is. And the highest honor that an expert can really have, you finish testifying, typically at trial, opposing counsel comes up, shakes your hands and goes, wow, you creamed me, but I'm going to reach out to you on future cases. That's really how the system should work. So what I really like about it is that Mr. Trentalange did his homework, knew that this expert had been there, that I'm sure has happened in cases and wasn't recognized. So he did it, and he's using it proactively and preemptively, because now on cross, they aren't going to have opposing counsel walk up and go, doctor, you're a paid expert in this case, aren't you? You're making $800 per hour to tell that you can't impeach him, because he'll say, gosh, that it's the same rate you paid me when I was your expert last year. So what it does, that fray doesn't exist anymore. There's no turning the case inward to disparage the expert. We now have to focus on the facts. So brilliant strategy.
Right. And the other issue I noticed was with the demonstrative here. He uses, a lot of times attorneys will approach it through a timeline of care and maybe take the expert through a timeline of care. This was a bullet pointed list of every way that this particular expert thought that the standard of care had been breached. And there was a lot of text there, but in its own way, it became its own weight. There are so many bullet points, and we'll see more and more of these bullet points throughout the testimony. They move from one PowerPoint slide to the other, going through all of these bullet points. So even if jurors don't get all of this down in their notes, they carry back with them the memory of slide after slide, reason after reason in this particular expert's mind and his opinion why the standard of care was breached. What do you think about that approach and that type of demonstrative?
So I think each demonstrative is tailored to the case. Some benefit from bullets, some don't, some need diagrams. This is a case about super simple math. There is a rate at which we raise a low sodium. It turns out they raised it 8 times too quickly. So in other words, in a 4-hour period, they raised the sodium by 16 points. Okay, I know those numbers might not have a lot of bearing now, and we won't get into them. But in a 4-hour period, they raised it by 16 points. The maximum rate at which you can raise it in 4 hours is 2 points, and many people would have raised it by 1. So the point being, I don't know what all demonstratives that they ultimately had, but those are the types of sound bites or demonstratives I'd want to have. What should you do, doctor? How should it be raised? Well, it should be 1 point per hour or half a point per hour. And in this case, it was what? It was 16 points in 4 hours, doctor. What does that mean? It's 8 times the speed limit for this. 8 times too fast. And again, using terms like speed limit, it's obviously not a speed limit, but there's things an expert can say and that you can work with your expert on. How would you explain it? So in other words, let's say in a case like this, her sodium was 116. That has no meaning to a layperson. To a doctor, that causes me, palpitations. I've got to address it. It's critical. To a layperson, they don't know what 116 is. So, doctor, give me kind of a framework on what would be sort of an analogy to that. Maybe I'd say something. Boy, that would be, for example, you having a temperature of 106. Okay, so that's not really what it means, but that you're trying to explain that's something you'd be concerned about. Absolutely. To a doctor, a sodium of 116 is like having a temperature of 106. You've got a problem that I've got to jump on. So that helps demystify numbers, a speed limit, temperature, putting it in terms they could understand. So I'm a big fan of working that out on your own case, which means you, the attorney, has to do your homework to understand it. Work with your experts to understand it, and then think of how you build those sound bites or analogies or expressions.
The next clip we're going to review goes back to that discussion of diabetes insipidus, and more generally, as we were discussing before, what you do, how you explain issues and failure to meet standard of care when a patient presents with some sort of pre-existing condition that can complicate things.
So now the next criticism we have is on coming on shift on November 30th in the evening. These are 7P to 7A and 7A to 7P shifts, right?
Yes.
And so you're talking about after he's gone home, and now Dr. Elrafati worked 12 hours and Dr. Furlan came back, right?
Yes.
So when he comes back on 11:30, are you saying that he should have obtained a consult?
That's correct. And
What specialty or specialties should he have consulted, and why?
And I think this goes back to as soon as he learned, or should have learned, of the existence of diabetes insipidus. So this would apply back to the first shift as well. Superimposing diabetes insipidus on the management of a patient who's presenting with a sodium of 116 and severe symptoms makes it more complex than a simple, never simple, but a straightforward case of just the low sodium. Now it's low sodium where the management is going to be complicated significantly by the presence of diabetes insipidus and the dependence upon desmopressin being given properly to control the rate of rise of sodium. I think that's the exact situation in which consultation with someone who is expert in that is required. Endocrinology, specialists in all of our glandular functions, hormones, would be a perfect example of the specialty that manages diabetes insipidus. The other one is nephrology or kidney specialist. They also manage diabetes insipidus. So either or both of those to manage this, what is foreseeably going to be a very challenging case as soon as you know that diabetes insipidus is present.
Okay. And is that for someone who's even for someone who's got a lot of experience?
Absolutely. I think critical care doctors are well trained and generally very capable of managing hyponatremia by itself. When you combine it with this addition of diabetes insipidus, that's not a typical part of critical care medicine training. And I think that calls for additional help.
Would that be even more true if the critical care physician that we're talking about had never before treated a patient with diabetes insipidus?
Sure. I think when we learn about lots of stuff in our training, but don't necessarily see it in practice. So it wouldn't be uncommon when you encounter a significant condition that has major potential impact on a patient's outcome for the first time. It's very appropriate, reasonable, and expected that you would call in consultation for assistance in managing that case until you really feel comfortable doing that yourself.
Right. So what were your thoughts on that particular piece of testimony in addressing that need to call in a consultation?
So he does a great job. The defense may argue, well, the doctor's a critical care specialist. The doctor's there. The doctor's treating it. The doctor knows how to treat sodium. What the expert is saying is, wait a minute, this isn't just sodium. This is a rare disease. In fact, we know from the doctor's deposition, he'd never treated it before. Again, most physicians may have never seen a case or been involved in it. So we need to pull in specialists. That's why we have specialists to consult. In the old days, you really need to call in specialists because if you didn't have a textbook sitting on the shelf, you'd be in trouble. Now people will real quick on their phone, they're on UpToDate or Medscape or other sites. So we do have tools that we didn't have to answer simple questions or give us a quick foundation in a rare disease. But the point is we've got a critical sodium, a life or death sodium, depending on how this is managed, superimposed on a rare disease. The standard of care is to pull in a specialist. So what I like is that he was pretty emphatic on it. It can be an endocrinologist or a nephrologist. What I would have liked a little bit better, and this sometimes comes back to expert coaching. Again, he's a 10. He did a phenomenal job. But remember, he just said a moment ago, I think that, mandates calling in X, Y, or Z expert. I always want experts to be authoritative. The standard of care mandates calling in a consultant. That can be an endocrinologist or a nephrologist. I would typically call in both. But we always want to work with our experts. Let's avoid probable, might, maybe, my preference, or at our hospital, or I think this is. We just want experts to always be in that authoritative, affirmative speech pattern. And that's very important when we have to be testifying to a reasonable degree of medical probability. So just throwing that out there as well. And this just comes back to working with your experts, although again, phenomenal job.
Now, the next clip we'll be looking at involves the other doctor that was one of the first wave of physicians that treated this particular patient, Dr. El-Rafati, and how Dr. El-Rafati managed this sodium imbalance.
Did he order DDAVP at all?
He did.
And are you saying it just wasn't enough?
I'm saying that the order in totality was inadequate. It was the wrong route. He ordered it nasally instead of IV, and he ordered it on a twice-a-day basis, and he ordered it on a routine twice-a-day basis. And the impact of that was that when you order a medicine twice daily, it's called a BID, it's Latin for, basically translates to 2 times a day. There's, in most hospitals, that automatically means that you dose it at 6 p.m. and 6 a.m. So Dr. El-Rafati saw the urine osmolality of 109 that was obtained at 2:07 p.m. that with the patient with sodium that's rapidly continuing to rise, should have ordered IV desmopressin on a stat basis. That means give a dose now, because we got to put the brakes on this process of all this urine pouring out. Instead, he said, give the nasal spray, give it twice daily, but the impact of that order that he wrote at 3:35 p.m. is that the next dose of nasal DDAVP didn't get given until 6 p.m. because it was written as a routine medication. So it was the wrong dose, the wrong timing, and the wrong urgency of administration.
I loved everything about that. He was succinct, he was emphatic, he's got hand expressions, and there is no gray zone. This, well, there's some options. We could give it, nasally, or maybe a pill. wrong dose, wrong time, wrong route into the patient. So very powerful testimony right there.
Yeah, one of the things to your point, one of the things I really liked about that was he started it off with all of those points. He ticked them off on his fingers. Then he went into detail, and then he reiterated those. He repeated those same points, ticking them off on his fingers.
Oh.
Exactly. And was very forceful in doing it. You could tell when he was talking about the urgency, you could feel his passion in this and his belief in this. And I think that resonates with jurors there.
Right. He stepped out of the expert role. That's him as a physician, as an intellect, as a master in his field. That's not advocacy and being an expert on the stand. He's thinking, man, if that was my patient, I'd be losing my marbles. So again, what a great style. Hats off to how that's put together, how he summed it up in the direction, obviously, he's getting from Mr. Trentalange.
And that's and to that point as well, I did think Michael Trentalange did a very good job of asking the question and then kind of stepping back and not jumping in too frequently. Sometimes attorneys will jump in too frequently with their questions and not let their expert draw things out and let the expert's personality shine through. And this expert had a very powerful personality that you could see would likely connect with the jury.
Absolutely. It's all about the flow and the balance. And when someone's on a roll, to interrupt them because you want to drop in a soundbite or you're going to change tack, just don't. If there's a lull or someone's stuck, absolutely a time to step in. But when they're on a roll, don't suck the energy out of that room. And again, so they had a nice back and forth.
It was really powerful testimony that really I think was a key to setting up that big verdict there. Any final thoughts on these type of cases?
I guess I just go back to the importance of really taking your time to do the homework. This is a complex case. The legal team understood it. So you can't take people down direct and cross and all these pathways and guide a jury if you don't understand your own case. A lot of cases we get involved with where people have very different depths of understanding. And I think what really makes a great trial attorney is when they can almost fool the expert, and the expert's like, do you have a medical background, or how did you, when we start asking, how did you learn that? You've done a great job, because it's not about fooling anyone. It's about taking the time to care, understand it on your own, working with your expert, and you'll serve your client the best by far on these complex medical issues.
Fantastic. Well, I think that was a great breakdown of that testimony, which was really key there. And Dr. Bentley, I want to thank you for taking the time with us today. And everybody, we will see you on the next Medical Testimony Masterclass.
Looking forward to it. Thank you, everybody.
Take care.